Hello folks, this afternoon we're going to talk about a little different subject. We're going to talk about palliative and hospice care. We're going to look at a couple of things. Does EMS really have a role in palliative and hospice care? If you have a role in it, do you need to change things, the way you're doing things now, to make that actually effective? We're going to talk about a new program that we have here in our department and a partnership we formed with a local hospice organisation. We're also going to look at the family perspective, and we have a family member that will talk to us later on to show how doing this well and maybe doing it differently actually has a positive effect on the families. I'd like to introduce you to some of the people that we're going to have our discussion with today. Jonathan Bartels is the palliative care liaison at one of our larger hospitals here in the area. He also does trauma nursing in the emergency department. He's been a nurse for approximately 20 years. Don Moore is a staff chaplain at the University of Virginia. He's over 40 years of ordained ministry experience, 20 of which have been in the hospital chaplain setting. He's also a board certified member of the Association of Professional Chaplains. Essie Rossi is the Director of Patient Services at the Hospice of the Rapidan, and the Hospice of the Rapidan is also the particular hospice that we're going to form our partnership with. She's 20 years of palliative care nursing and 38 years as a nurse. She's also certified as a palliative care nurse. So folks, I was doing a little research on this before we came in today, and there's some astounding figures that I didn't realize myself at all. About 1,600,000 people per year avail of hospice care in the United States. A phenomenally large amount of people. Something that I had no idea of them. Just like the population seems to be increasing, the numbers seem to say that between 10 and 20% of that number will increase every year on top of that again. So patients in our communities and in our hospitals and the people that EMS will see on a daily basis, it just seems to be that this is a number of patients that is just marching forward as the years go by. Do you all see that in your own personal experience?
Well, my dad, he left us a couple of years ago, but he had wonderful hospice care in Florida, and I was aware of hospice, of course, already, but it made a profound impression on me, and how significant that was. And in his case, they were able to stay at home, and he died with his wife holding his hand and quietly.
Yeah, the way it should be, probably. And Essie and Jonathan, do you see a caseload increasing in both your practices?
In my practice, we have an aging population, and it's only getting older. So because of that, and because people are surviving longer, people are being subjected to more and more quote-unquote terminal illnesses that shorten their life expectancy.
Absolutely, and with the baby boomers, there's a multitude of them, and their wish to have their own wishes honored. Hospice and palliative care only serves a very few compared to the number of people that die each year. So it's an ongoing hope to serve even more patients,
Wow.
more people in the United States.
So you see the increase in the patient load as not necessarily being a negative thing?
Absolutely not. We all are going to die, and the choices that we face, it can be on life support in a hospital, being treated for things that don't necessarily need to be treated, or it can be at home where most people really want to be, and that's at home, and enjoying whatever time they have left. And sometimes that time can be used up being admitted to the hospital, going back home, being admitted to the hospital, going back home, when those unnecessary hospitalizations can be lessened or ended totally with excellent palliative care, with the partnership with EMS that can respond and say, you know, here we are, but there's no need for us to transport you to the emergency room, because the emergency room is going to do this and send you right back home again. So,
Right, and one of the questions I think I would ask, maybe I ask it to Jonathan, is you've been doing this for 20-some years. You have a vast experience, you know, of seeing EMS coming in and out of hospitals. Do you see any changes or a void in the present paradigm of how EMS deliver care to this particular subset of patients that would be needed to be changed in order to have a better, more effective palliative care treatment of these folks?
I do. I think if we could circumvent bringing patients into the hospital. If we could circumvent, if they don't want to go into the hospital any longer, but provide the care they need at home, to symptomatically release or relieve their symptoms of shortness of breath or pain. And if they have opted to stay home with hospice, then EMS could serve a role if the hospice agency couldn't get there. EMS has an easier way to arrive, and they have the medications, and they have the experience and the know-how to administer them, and administer them in a safe way.
And Don, I'd ask you, from your position as a chaplain who would see these patients when they're admitted to the hospital, is there a common thread between the patients who are there, and they may be there because they were brought there by EMS, and then somebody felt an obligation to admit them to the hospital? But generally speaking, do the patients you see and counsel, do they want to be in the hospital, or would they rather be at home?
I think generally they would rather be at home, all things being equal, and with their families. I think most people want that for a lot of reasons. It doesn't often, I mean, I don't know what the statistics are, but it doesn't end up that way in a number of circumstances the way folks would want it to be. And there's a lot of reasons, I guess, that contribute to that.
And I think we can talk about that as we go on about a little later in the discussion about flexibility in the plan. You know, if you're very dogmatic and we will only do things a certain way, well, the course of your disease doesn't read a book and it doesn't obey the rules. So you may have to go to plan B, and EMS may well, that's where we often get involved, is when things aren't going right.
Right, that's why you're called in.
We're called, yeah. And basically we're called to, you know, to help out with plan B, to see what's going to happen. I think before we go any further, though, one of the things we should do, we're talking about this palliative care and hospice, and in talking to several people before we came in here, I got the distinct impression that, first of all, the expression palliative care was very much misunderstood. There seemed to be a very dark feeling about it. Oh, palliative care is about death, and it's very depressing, and just all around it's a bad thing, and we don't really want to talk about it. Can you all define for me, what is palliative care?
I can address part of that, and I'll let Essie address the other half. Palliative care, it has its roots in symptom management. What I do as a palliative liaison is different than a hospice nurse in the fact that I am in a patient's life from sometimes the beginning of their diagnosis to help symptom management while they're being treated. They may be getting radiation, they may be getting chemotherapy, they may be seeking aggressive treatments to try to eliminate the cause of whatever illness they have. Our role as a palliative care team in hospital and as an outpatient is to actually take care of some of the symptoms and side effects of those treatments. It doesn't mean that the patient, from a palliative care standpoint, they can be someone who wants to live and wants to have aggressive treatments, even to the point of being resuscitated. But it also encompasses those who would rather stay a DNR, DNI, and not have aggressive treatments done beyond a certain point.
Essie, one of the things that I hear out a lot when I talk to EMS providers is that they think that all patients, no choice of their own, must be DNRs if they're in hospice. Is there any truth to that? How does that actually work in reality as regards to those type of choices that patients have?
Well, when the patient decides and the family decides, because the patient and family are the unit of care for hospice, it is decided that they want comfort care, symptom management, and the support of the team of folks at hospice. The patient many times has already said, I want to be a DNR, I want to sign the papers or whatever. But we do not have a fast and furious rule that says that a person cannot have hospice if they have not signed a DNR. We want to honor the patient's wishes, and that is just the most important thing when it comes to palliative care and hospice, is a person deciding for themselves what their wishes are for their end of life and what their wishes are for their medical treatment in general. So many times we start with a patient and they're like, I don't want to sign a DNR, and we say that's perfectly fine. What you have told us already is that you want to be at home. You want to be comfortable. You realize that whatever illness you have is limiting your life here on this earth. And we will work with them, and many times they say, I don't want to be resuscitated. I don't want to be put on machinery. That, to us, is their admission that they want comfort care. And if all is in agreement, many times we have a patient at home that never signs a DNR, that is having compassionate care at home, having hospice people coming in and out, and they die a peaceful, dignified death at home without ever signing a DNR.
In that case, I think it's reasonable to say that there's a de facto DNR. They have expressed their intent and their wishes to you.
Absolutely.
And that's one of the things, one of the guidelines we did change here before this was to expand our policies to take into effect things that were expressed wishes and not to be quite so rigorous on a piece of paper, and to have a little bit more broad-minded approach to something that had traditionally been looked at in a very myopic way. You have this piece of paper or you don't. One of the things that I'd like to mention, you know, people say every now and again, you'll hear people say, well, EMS don't do palliative care. That's not something we do. It's not something we should do, and we have no business doing it. And it always seems odd to me, because if you're going to define palliative care as the palliation of symptoms, relieving of symptoms, is not then everything EMS does palliative care, and the emergency room too? You call EMS because you have chest pain, shortness of breath, whatever it is. You're not calling me to fix your disease process. You're calling me to take care of whatever is happening to you because of that problem. My chest pain, my nausea, my shortness of breath. And that's what we do. Is that not in and of itself? EMS doing palliative care every day of the week?
Relief of suffering. Absolutely.
Anything, whether it be extreme suffering or we palliate the symptom.
Right.
And that's what seems to me to be so odd, that when you mention this scary, spooky palliative care word, that people immediately go to one place, and it's a very dark, dying, end-of-life place. But we palliate things every day. That's what we do for a living. That's what all of you do for a living.
Palliation.
Yeah.
Exactly. And many times, from what I know of EMS, you go out and you relieve that suffering or treat them somehow, and the gentleman says, I'm not going to the hospital. And you evaluate and decide that you can't take him to the hospital against his will. So you have palliated his troubles for the moment, and then he has made the decision to stay home. And he doesn't have palliative care, and he doesn't have hospice, and he's just a gentleman that lives at home, and by golly, he was having a big issue right then, but you went, you alleviated whatever problem was needing emergent care, and he decided not to be transported. So that's palliative care.
CHF is a perfect example. You often will pick someone up, give them nitro.
What is CHF?
Congestive heart failure. You'll give them you'll give them nitro. You'll give them Lasix. You'll clear them up, and they may say, "Hey, man, I want to turn around and go home. I feel great." They have that right to do that,
sure.
And they have the right to refuse that care. But again, you're absolutely right. Palliation is something we do as healthcare providers.
And we haven't done, in any of those cases, we have done nothing, nor did we ever intend to do anything to address the primary disease process. We took care of what the disease process was causing a problem for them on that given day. So I would offer to you that when you think of palliative care as not being your role and nothing to do with what you do in EMS, give a little deeper thought. It's everything that you do in EMS. But having said that, in order to do this and to come up with a guideline like we have come up with together, there were necessary changes that had to be made. And the sort of traditional paradigm for EMS, and I think most of you will agree with me, is EMS goes as a result of a call for some form of service. They evaluate, they come up with a working diagnosis, they treat, whether that be procedurally or with medicines or whatever that may be, and particularly if they're given medicines, and particularly if they're given narcotics, nearly all patients go to some facility. And in order to do this, it's necessary for you to come to an agreement with all the people that administer your organization, your medical directors, in-house chiefs and what have you, that paradigm has to change. Because if we're to do that, we cannot then satisfy what everybody is saying is the basic wish of these people is not to be bereaved from the home. They want help, but if that help is going to come at the price of having to leave home because of it, you've sort of forced them. If I'm going to help you, you have to let me take you away from the house. And if it hardly seems a choice if you really didn't have a choice. What do you all think as regards the necessity to change those policies to where patients can be treated and left in situ, right at home where you met them?
I think it's dependent on the patient and the condition and the choices they make, obviously. And if a patient is at home and they're opting to pass away at home and they verbally say, I'm a DNR, I'm not sure from a legal standpoint how that covers EMS at this point, but we all have to have, used to be a yellow piece of paper in Virginia, now it's a white piece of paper that had to be on or showing before EMS would not intervene, because they're legally obligated to intervene to save someone's life. I'm not sure how that is at this point.
Yeah, I don't think it's as black and white as it seemed to be, or black and yellow, whatever. Right. But what I'm trying to get to is, and what I'm trying to make sure we don't do is focus on the end of life, the last days, hours of life. Because the program we're involved in, when we look at the patients that we see, and in our department, when I look back at the numbers, and I'm sure this is representative of lots and lots of departments, those last hours or days of a patient's life represent a tiny amount of times we see those patients. It's much more likely that you're going to see the patient because he has breakthrough pain, shortness of breath, some nausea, and he's no more going to die that day than fly to the moon. He's just sick that day. Mm-hmm. So what I'd like to do is address that, the lots of time at the beginning and middle of the disease process that we're going to see him, how it's necessary to be able to treat him and say, thank you very much, we're leaving, you want us to leave, we're leaving. And that is a change that we've had to make in this department. Some places call it treat and release. But in order to achieve that goal and honor the patient's wishes, but still treat him correctly or she correctly, that's going to be absolutely necessary.
And certainly in hospice care, every patient has a nurse and a social worker assigned to the patient and family. And one of the social workers' goals in order to work closely with EMS is that we get that official DNR signed when able. And that's to help you all be able to respond in such case to the patient's needs that occur on an emergent basis. And regardless of whether they have the EMS DNR or not, we are really so focused on relief of their pain or suffering. And that's what we concern ourselves about.
And in the scenario I'm talking about, though, the DNR doesn't function. It's not part of this scenario. This is a guy who's 6 months, we'll say, six
Right.
months into his disease. We don't care if he has a DNR. It's not relevant or pertinent to the case. The issue that I'm trying to say is here, and see if there's agreement, is to take care of patients' symptoms at a time where we're not even worrying that the question of resuscitation comes in. He's relatively healthy at that time. He's just having a breakthrough or an exacerbation of his symptoms. We need to treat that, be able to treat that, and the DNR doesn't come into that. You have to change your policies to allow patients to be treated and not transported.
Exactly.
The difficulty is that I find in this is when patients are calling you for a pain crisis, if they are palliative care and not necessarily engaged in hospice, we don't have an agency that can be called in to supplement. There is no home palliative care at this point. There is a home hospice. But if they're sick enough or in pain enough or have enough shortness of breath to call an ambulance to have you guys come, there would have to be a collaboration with their physician to talk to the physician over the phone. And if that could be done, so the palliative physician could help guide the EMS crew in what medications would be provided, that could certainly, conceivably, if they're willing to do it, would be a way to meet that need and not necessarily bring the patient to the hospital. But often my patients, if they're in that bad enough pain, are usually admitted into a hospital because we have to regulate and we have to adjust meds to get them to the point that they are not in pain anymore. And it's not a simple increasing of a dose. It's not as simple as that. It's actually an art form to get that pain
Absolutely.
under
I
control.
mean, pain management itself, people make careers out of it.
Right.
So,
out of
John,
it
you're
a lot.
talking about reaching a level where they really need to be in the hospital to get the medication regulated.
Sometimes
Yeah.
done.
And I think that's probably, looking at what you're saying, is probably, for want of a better word, a second phase of a program like this, because our department is looking at this particular program, and as it starts, I'm sure it'll change and things evolve over time, but these type of changes are going to be in relationship to patients who are known and admitted to the hospice service. So we will there is that that known quantity, so to speak, that it's not a person who just has a chronic, painful condition. That really, I don't know that a lot of people are ready to address that one. But what we're trying to do is
Let me correct you in chronic pain issues, because palliative care is even separate from chronic pain. Palliative care always denotes a life-limiting illness. So it's not even chronic pain like chronic back pain or anything like that, but there is a delineation between that and what palliative care services provides.
life-limiting, but not necessarily life-ending.
Everything, we're all terminal,
Well,
right?
I understand that, but in this case, what I'm trying to say is, if you're defining this palliative care and the problems you're having as a patient limit your abilities in your daily activities, but don't necessarily, they aren't necessarily going to end up soon in the end of your life, to where you wouldn't fit in the hospice setting. You wouldn't be admitted to a hospice.
Tom, listening to you, or I wonder part of what you're asking is, or what I think I'm hearing is, for the EMS team to be able to make a little bit different kind of intervention when it's possible to not have the patient go to the hospital, but for them to consult with a physician and do whatever magic you guys do to palliate the concerns, to make them more comfortable, to bring the distress down so they can stay at home, that there is an option there that maybe the EMS teams have not, for a lot of different reasons, really considered possible before. And I wonder if that's part of what you're saying.
And I think that's a very good way of summing it up. What we're doing is, with this program and this partnership with the Hospice of the Rapidan, we're trying to offer people a reasonable option that traditionally was not available to them. And I think you sum it up very well when you say that. There is one other question, and I'd like to, once we sort of answer this one, it's the elephant in the room that everybody talks about. And then we'll go on to, we can all sit here and have an academic discussion about this. We're all relatively healthy and not needing any forms of these care. To get a real perspective on this, I think it's important that you see it from a real point of view. And we have a family member who's going to talk to us in a little while who has lived through this and seen it done in more traditional way for EMS and seen it done a little differently. and can give you real life feedback on what it means to the family to do it two different ways. So the big question that everybody talks about and pretends they don't really is medicines given to patients at the end of their life, and patients particularly who have real problems with pain, shortness of breath and what have you. The common concept and thought among some people, and certainly some of the people that I've talked to in EMS and some academic folks and physicians and all through the spectrum of healthcare providers, we actually cause the death of our patients by giving them narcotic. Is there any truth to that at all?
There's a truth in terms of how people feel, say if it's the last dose they give a patient, but that patient is terminal. They have either cancer, they have an end-stage cardiac disease, they have a myriad of other issues that are actually bringing them to the point that they will pass away. The medicine we give, the intent we give the medicine, is not to expedite someone's death. It's not to make it go quicker. It's to control the symptoms that they may have. They may be grimacing. They may have horrible pain issues. They may be gasping for air. Those are signs of suffering. And what we're doing with the medicine is giving it in such a way where we're trying to relieve that without causing harm. If they do pass away, from my perspective, they're dying from their illness. The medicine I gave them helped them to pass away without the suffering that may go along with it, without any medicine whatsoever.
And Tom, if I understand right, there's evidence-based now to actually demonstrate that you're not bringing about death when you're, is that correct? Or
yeah, I think so. I think Essie had a comment when we were talking earlier about that evidence base.
Absolutely. Being in hospice, which is a slightly different level than palliative care as far as based on Medicare rules, hospice is for people at end of life with a prognosis of 6 months or less. That's about one of the differences between palliative care and hospice. Hospice never hastens death in any way, and we do nothing to prolong life unnecessarily. We have found sometimes when a person is suffering with pain and their pain is uncontrolled, they sometimes die sooner than if they had good palliative care, good symptom management, good pain management. In the days before, we were able to rationalize the fact that medicines were given and the double effect rule that you and I have talked about in the past. And academically, that's true. If I am giving a dose of morphine and the patient's suffering is relieved and they die a few moments later, they did not die because I gave them the morphine. They died because their illness has finally worked on their body to where it has succumbed to the illness. So in no way was that dose of morphine the contributing cause of their death. The illness is what caused their death.
And
so,
Don, from a pastoral point of view, and I don't want to belabor this point, but it is something that I find, and I think we all agreed when we talked a little while ago, that even through healthcare providers, physicians, everybody, this is a thing that seems to be a sticking point from people. And really the sticking...
And the thing being...
They thought that maybe something I did as a healthcare provider killed my patient.
Moral distress.
Moral distress.
Absolutely.
From a pastoral perspective, can you reassure people that this is ethical, morally okay? They're not doing something that's really bad?
Absolutely, and even more to the point, I think probably what I get very sad about, you know, even around the hospital, is when people are in great pain, and I have even a lay perspective that there's care available that could help reduce that pain, and you know, and my heart is that they would be able to get it, and to reduce the suffering and to provide care for them and to to ease their distress and bring comfort to them. That's the mission that I'm on, and I don't see it as a link to to bringing about death. That's going to happen. But it's getting there, and how we get there, I guess, and how we live, even more importantly, up to the point that we're not here anymore.
I think it's important also. I know EMS because I have lots of friends in EMS, and I'm an emergency room nurse. Withholding pain medicine because someone has a low blood pressure, withholding medications because their O2 sats might be a little bit low, especially if we're talking about at this point in someone's trajectory of life, meaning they're about to pass away within the next days, hours, minutes. It's important to let go of those numbers and look at the patient and look at what they're offering you. They'll show you they're short of breath. They'll gasp for air. We've all seen that. They'll show you they're in pain. They'll be screaming out in pain.
That's the old thing that everybody always says, treat the patient, not the machines.
Right, exactly.
Or not the numbers sometimes.
Not the numbers. And
Exactly.
that's an old expression, but you can apply it to every field.
And that's what our heart goes out to.
Right. And I would
And families.
I would question the ethics of not giving the proper pain medication.
Absolutely.
In the recent past, we're talking about pain being the fifth vital sign that we need to address. All medical professionals must evaluate pain, and they must treat it. And to not treat it and not give that dose of morphine or dose of whatever narcotic needs to be given, that to me is the error in our medical professionals' judgment. We need to medicate.
But it is worth saying, when we talked about the changes that have to be made in the traditional delivery of care, EMS folks and most places are taught to be very conscious of patient status when given particularly narcotics. And traditionally you will find patients who are receiving large doses of narcotics, they're going to have all sorts of parameters monitored. Vital signs, heart rates, EKG rhythms, you name it, whatever. Where if you're going to have a guideline like this, this is going to run a bit contrary to how you normally would ask people to do things, because those numbers, as you talk about, there's significance changes to those numbers. And when your goal is achieving the reduction in the symptom, that becomes your higher guide. These numbers, as we see, whether it be, as John said, some hypotension or some change in mental status, that would normally in the healthy person that you're trying to cure, fix, is much higher. There's an inversion here in that. So your guidelines, if you're going to do this, you're going to have to address that. You're going to have to say that you can do things in these particular settings that would be done quite differently if it was for a young, healthy person.
And it's the dichotomy of the care. We as emergency providers are aggressive when we need to be. We'll do compressions, we'll intubate, we'll do whatever it takes in that emergent setting. You take the same mindset and you apply it towards symptom management. You'll get different results, but you'll relieve someone's suffering. It's difficult to do, but it's not impossible to do.
One question, sorry Don, you had.
Well, I was thinking about bringing comfort to emergency service providers. That's an important part of what we're doing. And it sounds like to have some guidelines and protections for them in terms of new protocols. Is that what you're working on?
Well, yeah, we will have in our particular
be
department,
very specific.
It will be a very specific. We try not to use the expression protocol. We try to go by guide. No, we try to go by guideline because we give folks a range of options and hope that you'll use clinical thinking to decide which one it is. So we don't do A follows B. Right, exactly. We say here are the ranges that we would like to see you, or the things we'd like to see you do. Please make a clinical decision where in that range you'll be. Do you individually, from your clinical experience and your practice, A, think that EMS should take a more, shall we say, should take an expanded role in the treatment of patients needing palliative and/or hospice care? And do you personally recommend it? Would you say to people, please look at this, this is a good idea for your department or agency?
I would say there's a protocol we use in the hospital when we're discharging someone to a nursing home and they're receiving end-of-life care. And in that order set, there's an order that says do not hospitalize. If a hospice patient has that order set and is still committed to that, and the hospice agency can't get to them, I think EMS can play that role until the hospice nurse is able to get to them and able to assist the family if they're having difficulty with the medications. So yes.
Okay, Don?
Unequivocally, yes. And I say from, again, I think somewhat of a lay perspective, empower the EMS folks to have the power and the confidence to make these decisions, to move, to be able to bring comfort in consultation with physicians, whatever needs to be done in their situation.
Essie?
Yes, I do. So much comes back to patient autonomy and the ability for a patient to speak for themselves. And in my many years of home hospice, 20 and years of nursing, if a person has expressed they want to stay home, I don't feel that EMS or a different family member or whoever should have to, because of their protocols, have to transport to an emergency room to answer to their directive that go, treat, transport. So absolutely, yes.
What I'd like to do now is I'd like to welcome Jeff Dotson. And Mr. Dotson is a dad of one of our patients that we took care of here in our department. And we took care of him in something that's quite akin to this new guideline that we're going to start. There are more expanded things in this new guideline, but certainly as regards taking care of the patient in a more holistic way, that's certainly how we partnered with his family and chose to take care of him. So, welcome, Jeff. Your story is, I think, one that's going to resonate with a lot of people, and especially any people who've had a family member, and in your particular case, a very young family member, go through a terminal disease and their death. First of all, though, tell me a little bit about Joey himself and the situation you were in.
Joey was a 26-year-old male with Duchenne's muscular dystrophy. He was diagnosed in 2006 with some respiratory issues, also some swallowing issues. So he received a G-tube and a trach in 2006. Also was on a ventilator just at night. February of 2013, he was diagnosed with a third-degree heart block.
So when I got to meet you and Joey first, I had heard, from the crews here had actually gone to your house, and they had come back as part of the QA process, and they had told me about this particular person that was down there that had Duchenne's. And I contacted you and asked, would it be okay with you and Joey that I come and do a home visit? And that's one of the things that I think is very important, getting to know these patients, because each patient is very specific in their desires, their needs, the course of their disease. Just because you have muscular dystrophy, or in this case Duchenne's muscular dystrophy, it doesn't mean that it's going to follow the same course with you as the next person. So your care has to be very much tailored to that individual and the situation, the family. There are many, many factors that go into this. And what we at our department, and I personally feel, is the time to start honing this relationship down is not when the family call you, as we were talking about earlier on, when things are going bad and you're the source of plan B, it's not the time to actually get to know the family. So we came down and we had a discussion. And what do you remember of that discussion? What a part of that discussion, or just having the discussion at all maybe, was different in how EMS took care of Joey? Because you lived in other jurisdictions and,
Yes,
and had occasion to meet other EMS agencies.
It was a very, very good idea, very good experience. Because I remember you saying it's better to meet somebody and before they really need them. I think it was a very, very good idea. Joey agreed that it was a very, very good idea. He talked about it for months after that.
And I know when I left there, I mean, don't get me wrong, when you have these conversations, you go down there as the healthcare profession. You know, I've been doing this close to 30 years, and certainly have had these conversations before, but you'd have to be a total psychopath not to take away from those conversations, you know, strong emotions. I remember meeting Joey, and part of that conversation is we talked about, you know, because at that time it was clear that he wasn't going to die very soon. So there was going to be ongoing ups and downs in how well he was. And we had a conversation about how we would deal with that. But we also had a conversation, I remember very distinctly with him. I asked him, what should happen, what would you like to happen if we come down here your very last day, the day that you're going to die? Let me tell you what's normally done. And Joey had at that point was becoming more ventilator dependent. So having a very open chat with him was difficult because I had to learn his communication. You had to teach me how he communicated. So that there was a huge learning process to go on there. But I took home from that two things really. One was, for me, it was quite sad. But the other thing was the phenomenal resilience that he had, and the resilience that a family had facing this thing. It was coming. The train's on the tracks. It was coming. There was no way around it. And with your permission, when I came back to the department, and Joey's permission, we did an in-service for our department. And his case is unusual for hospice care because he was on a ventilator, which is just usually not synonymous with hospice care. So we did a thing where everything was how that port event would be used, the particular model, you know, where things would be in the house, a little bit talking about, you know, Joey, because when you, at that point in his disease, when you met him, unless you knew him, you wouldn't maybe think that he was able to converse and understand everything you said. So the idea was that when, and I know you said this to me when we talked before, you know, there were no strangers in the department when they come to see him. We saw him several times over towards the end of his life. He might not have seen the people before, but they weren't strangers because he knew they knew about him. Right. So they weren't just total strangers coming in the house. And that's how our department, and that's how this new program we're going to have, and hopefully with the help of the hospice, we're going to have a little bit more information. We'll know these people. They won't be just people we see and go away. We'll know a little bit about them. Hopefully we'll be able to do that home visit. But the home visit alone seems to be very successful. Yes. From your perspective.
Yes. I mean the whole lot.
And you would encourage, I'd take it, probably stating the obvious, but you would. Don, go ahead.
What meant so much about the home visit?
Well, just like I said, Joey talked about it for months down the road. We lived in other counties, and nobody ever did that. Now, probably here in Orange, Joey got more sicker than he did in other counties. But just like I said, nobody ever came to the house and coming that day for an hour and a half and just talking to me and Joey and
spending time caring for him.
Yeah, it meant a lot.
Yeah, we just sat in the living room and chatted that day.
Yeah, it meant a lot.
Chat about the whole thing.
But just like I said, Joey talked about it for months. So it meant a lot. Cool. So I think a very, very good idea.
Okay, from your perspective, Jonathan, we do a lot of procedures, we give medicines, and Don as well. You chime in here because you see these people in a pastoral respect. When you were to weigh up procedures, medicines, and medical stuff versus the more holistic, humanistic sort of getting to know the person and just chatting to him, where's the weight in that? Are they equal? Do you think the patient, you know, like in Joey's case, he seemed to want people to know about him, and the fact that they were not just knowing the clinical and technical things about him, that they were really interested in Joey, in the person. How therapeutic is that for the patients when they're going through this?
I think it's essential to humanize a patient as opposed to prognosticate a patient or make them into a disease. I was blessed to know Joey and his dad took care of him at UVA and other spots. And I was just honored to, I think it's essential to know your patient, because if you dehumanize a patient and only look at their disease, you miss so much over the uniqueness of what you have in front of you.
Of course, from my point of view, it's at the heart of things because caring it becomes so meaningful throughout the whole course of life. But at that point, it's very significant to family and to patients. And I tend to take, again, from a lay perspective, best medical practice for granted. You know, that's going to be done. That the best medical things, and that makes a big difference. I don't want to undervalue that. You know, that pain is taken care of, and that the best medical things that need to be done are being done. But having said that, you know, being able to give personal care and I think what EMSs do all the time, and in terms of when you're trying to give medical attention to a patient, trying to comfort them, just how far, I say in the hospital, just how far kindness, just plain human kindness goes, just consideration, just respecting somebody's dignity and consideration. A lot of times silence, you know, you don't have to be afraid of, well, I know you're busy paying medical attention if you're in EMS, but just listening to people and hearing their stories, and if you have time for that, you're able to do that. It's priceless. It's absolutely right.
I think one of the things you can probably say, and Jeff, you can probably, you know, chime in here on this one, we've become, from your own experience, we all have medical experiences, we all have our own things, we see doctors ourselves, we go to hospitals, whatever, we have that medical experience, and things have become so time dependent, things have become so time dependent. You have so many minutes to see a patient. You do this procedure. We must do this quickly. This must be done in the EMS. You know, there's great pressure to do things in time frame. And the old country pastor or the old country doc, what did he do? He sat down and chatted to you.
And listen. Yeah.
And listen to what you had to say. Now, I'm not saying that we should get away from the enormous advances and the curative properties of what modern medicine has, but maybe we should let the pendulum swing back a little bit to where we do spend some time with our people and get to know them. Even if it's only the EMS call, well, you may never see them again. Small chat, you know, makes it easier. It makes them a lot easier people to deal with if they see that you're actually just going to be nice to them. They're not just that day's medical crossword puzzle for them.
We all went into this because we care about people.
Yeah.
And this is a simple act of caring. And as Don said, being kind. It's important. If you're not doing that, then you're in the wrong place.
Yeah, and you know, some people, I think you have to make a special effort, and this is a whole subject altogether, but not everybody's easy to be nice to.
No.
And especially as time goes on and they're in this situation, some people's response to that is they become less easy to get on with?
Well, it could be any one of us, too.
Not me. Not me.
You know, if you're in medical distress, you can get upset and
Yeah.
you can get angry, and you know, the person nearest to you, who might be a family member, but also might be the EMS provider, and you know, you're scared. I know a lot of times for men, fear translates to anger. You know, if you're afraid that it comes out that way.
Well, I don't think you'd mind me saying, but there is no doubt whatsoever that Joey knew what Joey wanted.
Absolutely.
And Joey was going to let you know what
Absolutely.
Joey wanted. And should you err in what Joey wanted,
Yes.
you would be rapidly...
And he would probably let his father know before he would let anybody else know.
Yeah, he would rapidly let you know how you
Yes.
should amend your
Yes.
ways.
Yes.
And if he's going to be upset, he's going to be upset to his father more than he was EMT, hospice, the nurse,
Yeah.
or the doctor. So
You're the one that was really close to him. Yeah.
And we talked earlier on in the discussion about one of the things that a program like this, one of the benefits it would have, is it would allow you to treat patients and not take them away from the home. Now, Joey wanted to be in his home. There's no doubt about that. Everybody agrees on that. And there were times where Joey had to come out of his home. Not real thrilled about it, but he had to come out of his home.
Yeah.
For the times, though, that we did see him, he didn't always have to go. And there were times where he would have, if you were to look at the traditional way of doing it, he would have gone anyway. And I remember there being a time or two where I got a call because the thought between you and them was he probably needs a follow-up with somebody, but not to go to the hospital. And, you know, even that it was the sort of looking like you were looking for somebody to tell you it's okay, leave him in the house. So even for our guys who were given more education and were given the freedom to make these decisions, typical EMS, it's kind of odd. It's not an easy feeling for them. It's not what they're used to, and we struggled as hard as we could to try to make sure that where it's in the care plan for the patient, not our care plan, and not the medical guidelines of your department, where it's in the care plan, what that patient has decided is the road that they want to take for their particular situation, to do your best not to get hung up in the, well, we always do it this way. Apply it individually to that case. Do you think from a family perspective, and certainly, you know, now that Joey has died and you're left looking back on it, do you think those times where the decision was exercised not to take him to the hospital, do you think that was beneficial or complicated things more? Do you think Joey was happier on those days where he knows he didn't have to take a ride to the hospital?
Well, I can remember times that it was kind of confusing, but you had a couple different people telling you different things. He had an excellent team of doctors that's been following Joey since he was little.
Yes. Yeah.
So they would tell you to bring him,
Yeah.
but then they would say, no, we know Joey's not comfortable here.
Yeah, they were struggling themselves.
But
yeah.
Probably
what y'all said earlier about the numbers and the machine, a lot of numbers was off, and the machine was too. So they couldn't really say, no, not bring him. They know he didn't like it, but so a lot of confusion.
But the general
Trying to navigate that.
Yeah, the
Right.
general concept of where possible, and I understand that we're talking about Joey in this case, but using him more as an example for this whole group of patients.
Right.
If they can stay in their home and be treated, so the option is not stay in your home but don't get treated, where they can have the best of both worlds, so to speak. From a family's perspective, do you think it's better for them to stay at home?
Absolutely. 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 If that's what they want.
And Joey was able to do that some, was he?
Yes, he done it a lot.
In cooperation with the medical team and with the EMS and everybody.
So Jeff, you've told us I think in a quite real and moving way, the story of Joey's illness and eventually his death. Lots of things you raised in there, but if I was to, in closing, just ask you, pick the top 3 things that you think are necessary to make all this other stuff, all the physicians, the nurses, the pastors, everybody working together. What do you need to have to bring that all together and make it successful?
Well, the first thing is probably communication. And that is a wide, broad word, communication. The next one would probably be patient and family patience. Patience with the patient. And Joy was probably the excellent patient. And the family has got to have patience too. And the last one would be love. You got to love everything. You got to love what you do every day. It's days that you're on your own. So you got to pick the other things up, you know, the communication and the family patient.
Okay, so that's probably a very good point to leave this. I think it's a very real perspective on how everything we've spoken about earlier on comes together for the folks that are the most important ones, which are the patients and their families. We'd like to thank you for joining us today. We'd like to remind you to visit our partners at clinicalbraintraining.com, and we will see you for the next time we do one of these.
And 5, 4, 3, 2,